Good morning, all. Can I just get someone to give me a wave, making sure you can hear me? Great, fantastic. Thank you so much. Thanks for joining in. We got a few people still joining in, so I'll let them in as they come through. But we've had 115 people who have registered so far. I've got 47 so far here. So as they come through, we will let the rest of them join in. So as I mentioned before, we'll try to kickstart this on time, so we'll progress. My name is Siavash Dustra. I'm the Director of Youth Affairs Network of Queensland. I will facilitate the meeting today. I'd like to begin by acknowledging that I'm here walking on Aboriginal land, particularly the Turrbal Yagara people of the Greater Meanjin, also known as Brisbane, and pay my respect to elders, and hopefully that in this meeting and everything we do, we can keep the issues of what it means to our Indigenous brothers and sisters in the forefront of our thoughts and actions. I'd like to introduce to you Cynthia Kennedy, who is the Director of Community and Corporate Partnership in the Department of Communities. Cynthia's got a message on behalf of the department, so I'll pass it on to Cynthia.
Thanks, Siavash. Sorry, rapidly reaching for my unmute button, as we all have become practiced at doing. I would also like to pay my deepest respects to the Aboriginal custodians of the land on which I live and work, the Yagara and Turrbal people, and all of the lands from which you all join this meeting today, and acknowledge their leaders and emerging leaders. Can I pass on the apologies of the Minister Di Farmer? As everyone would be well aware, the government is in election mode, so the department wanted to proceed anyway with this function with Siavash and Yank, even though we do that from caretaker mode. The Minister otherwise, of course, would have joined the forum, and we look forward to engaging with whoever our new Minister may be in about 20 days' time. As I said, this forum is being facilitated in partnership between the Department's Office for Youth and Yank, and I just want to thank Siavash for organising it, and thank all of you for joining. It's going to be a series of forums, starting with this one on mental health. I know that Siavash surveyed the sector, and the topics that came up as the most important were mental health, re-engagement with education, and housing security and stability for young people. And there's no surprise that those are the critical issues facing particularly vulnerable young people, and only made worse by the impacts of COVID. These forums are intended to be an opportunity to connect with each other and connect on the issues, and formulate some ways in which we can work together to help young people overcome these barriers. I want to thank the sector more broadly, both from the department and, of course, from the Minister's perspective. The youth support sector has shown incredible resilience in terms of coping with the COVID impacts, and continuing to provide as uninterrupted as possible support for young people. And I just want to thank you for the work you've done in adapting. I'm trying to avoid using that word pivot that everyone seems to be obsessed about at the moment. But of course, we all have just done whatever we can do to continue to provide support, particularly for people whose vulnerabilities are made worse by the impacts of COVID more recently. So thank you. I'm really looking forward to the discussion. And sorry, Siavash, that was probably a bit longer than you were expecting.
No, thanks very much. Appreciate that, Cynthia. The agenda today is that we have a guest speaker that I'll introduce to you in a second, and then that'll be followed by a Q&A session. So you'll have the opportunity to ask our guest speaker any particular questions you have. If you have time, we might start exploring what basically the issues mean in terms of its impact on the youth sector in our work with young people. Because the forum is going to be very short, and we're going to try to keep it in time, but we might go a little bit over 1 hour, depending on the questions coming. I've decided to put a Survey Monkey out, so that'll be emailed to you after the meeting with a number of questions in terms of how to proceed from here on. What does this mean in terms of policy, in terms of our practice, in terms of working with the government, and in terms of our work together as a sector. So you'll receive a Survey Monkey, and I'll urge you all to respond to that one when you receive that afterwards. Please keep your mute buttons on unless you're actually talking. And if you have a question, please put your hand up through the using the participant tab, and then the hands up there. So I'd like to now move into introducing John Jureidini to you. John is a child psychiatrist who heads Adelaide University's Critical and Ethical Mental Health Research Group, which promotes safer, more effective, and more ethical research and practice in mental health, and the Pediatric Mental Health Training Unit, which provides training in non-pathologizing approaches to primary care mental health. In his bio, John says that he has learned most of what he knows about psychiatry growing up in a pub. I'm interested to hear more about that, and from being a father and from reading novels. Amongst many other things, John is the chair of Australian Palestinian Partnership in Education and Health. So please welcome John with the Zoom style, I guess, a bit of a shake. On to you, John.
Thank you very much for the invitation. I feel privileged to talk to this group. I'm speaking from Narrandjeri land in South Australia. And as I interpret my task today, is to talk about the problems created for the youth sector, and more importantly for youth, by the medicalisation of young people's distress, for which my profession is largely responsible. Some of you will be aware that several years ago there was a Get Up campaign featuring Pat McGorry, who was then relatively recently Australian of the Year, with a tagline of 750,000 young Australians locked out of mental health care that they desperately need. And that campaign led me to coin the term the McGorry conflation, because I think Pat was confusing two different populations. There is 1 or 2% of young people who sadly need or might benefit from having somebody like me in their life. But McGorry was referring to the 20 to 25% of young people who on community surveys turn out to have a significant level of distress that manifests itself in a way that could be interpreted as eliciting a medical diagnosis. Most often something to do with drug and alcohol use, but also depression, anxiety, adjustment disorder, those kinds of things. And there's absolutely no evidence to support the view that that 25% benefit from coming into contact with the mental health system. Intuitively, you might think, well, if these people are significantly distressed, wouldn't it be good for them to have a mental health consultation? Well, actually, we don't know. So, but the impact of that, I think, is that young people are being driven out of your sector and into my sector. And I want to argue today that that's on balance is not a good outcome for young people. The reason for that is that there's lots of argument and energy and research going into what might be underpinning young people presenting with the range of what are defined as mental health presentations that we see. And there's a limited range. It's drug and alcohol stuff, there's depression, there's anxiety disorders, there's kind of conduct and behavioural disorders. as I say, most of the research energy goes into trying to determine what might the biological causes be and what the biological treatments might be. And that occurs in the context of having a really clear idea about what the social determinants of these presentations are. Now, you might need to treat what I say with skepticism, because there is no randomized controlled trial to demonstrate that domestic violence makes young people miserable. But I'm going to take it as a fact that that's the case. I'm also going to take it as a fact that poverty and food insecurity and accommodation insecurity cause depression. And the very same people who've been telling us that we should treat mental illnesses as medical disorders like any other because they've got biological causes are now saying, in the face of COVID, which is a social phenomenon, we can expect much higher rates of depression and anxiety, and therefore we need to be vigilant about what's being done for these young people. And the incongruity in those statements doesn't seem to be acknowledged by anybody. Nobody's saying, well, actually we've been overemphasizing the biological, and what COVID teaches us is that we've got to give absolute priority to social determinants of mental health. Nobody's saying that. The conclusion from what I've said so far is that the attempts to ameliorate suffering in young people and to prevent harm in young people doesn't reside primarily in the mental health system. It resides much more in the sector that you people represent. And if I was asked who are the most important people after parents in determining mental health for young people, I certainly wouldn't be talking about psychiatrists. I'd be saying teachers, and teachers and schools are the most important influences on young people's mental health, much more so than the mental health system. But sadly, as a society, we don't recognise that, so we don't remunerate teachers according to that kind of value, and we don't invest in education in that way. And but if parents fail, we've got teachers to fall back on, and schools. If schools fail, your sector is kind of the next line, for that reason is much more important than the mental health sector in determining outcomes for young people. So as I understand it, and please feel free to interrupt me if you want to take me to task on anything that I'm saying. As I understand it, there's considerable pressure on your sector to refer on to mental health services if certain indicators are met to do with risk usually. And risk aversion is a real danger to young people's mental health because by its nature, risk aversion leads to a loss of autonomy and a loss of agency, and the imposition of other people's authority on young people. Now, I'm not going to argue that it's never appropriate for those steps to take place. I'm certainly not saying that you shouldn't ever refer to the mental health system. And there are times when it's important that you are assertive in pushing young people towards the mental health system. But in the overwhelming majority of cases, I don't think that's the right direction to go. Certainly not with any level of compulsion. An offer of the mental health system or the medical system as one of a number of pathways that a young person might pursue, or their families or carers might pursue, is not unreasonable. But as the kind of go-to intervention, I think it's all wrong. And it's all wrong because the mental health system is itself risk averse, it overreacts, and on average it medicates. And even though the main sort of the people who own mental health in Australia, which more or less boils down to Ian Hickey and Pat McGorry, who on the surface advocate non-medication responses to young people's distress, nevertheless defend the use of medication and should be well aware of the fact that anybody coming into the medical system with a mental health problem is most likely to see a GP and most likely to receive medication as more or less the sole intervention that they receive. So when you advocate for somebody to come into the medical system, it's disingenuous to advocate on the basis that they're going to get what Pat and Ian would describe as optimal care in that system. They're not. And just as people coming into the youth system aren't necessarily going to get optimal care. But we've got to be realistic about what's available, and you don't have any influence, whereas you can work hard to improve the quality of care that exists in the youth sector, and you can take responsibility for that. You've got no control over the quality of care that's being administered in the mental health system. The second main reason why it's a bad idea to refer, well, why we should be skeptical about the benefits of referring, is that referrals very often don't work or don't eventuate. That, you know, in the medical system, I don't know what it's like in the youth system, in the medical system, only about 50% of people attend appointments that they're referred to. And even if they do attend, then you've got the doubts about whether that's going to be beneficial. And when we refer, we almost always refer because we think somebody else can do a better job of things than we can. And the reality is that all of us, the most powerful thing we're doing for anybody is the relationship we form with them. Now, if you've already formed a relationship with a young person you're working with, you're already at the point of contributing. You know, these figures are completely arbitrary and possibly meaningless, but I'd say somewhere between 40 to 60% of what that person is going to benefit from any intervention is coming from the relationship that you've established with them. When you refer them on, you're rolling the dice as to whether they're going to achieve as good a relationship with the next person they see. And so just because the person you're referring to might have extra skills doesn't necessarily mean that the person you're referring is going to get a better deal out of that referral process. A third reason for being cautious about referral is the mental health system doesn't respect, on average, doesn't respect the validity of suffering. And, you know, I have repeatedly been chastised by the powers that be in medicine for suggesting that taking away pain isn't necessarily the best intervention all of the time. And here again, no randomized controlled trials, and a much more contentious area than whether domestic violence is harmful. But I'm convinced of the fact that people can grow through experiencing distress and working through and resolving the grieving process that goes with a distressing experience. To be respectful of a young person's capacity to go through something very difficult and come out the other side. And our role as adults is not always to take away the pain, but to stand with the young person as they negotiate their way through the experience. Now, there's a very big caveat on that, which is that if someone or something is actively hurting that young person, then we do need to intervene to change that. If the young person's a victim of violence or bullying, or they're sick, or something else that is can be and should be addressed is present in their life, then our role as youth workers or psychiatrists or whatever is to intervene and advocate to stop that from happening. But if we're in a situation where a young person, as so many of the young people we see, is suffering because of something that happened in the past, or some realization in their life, somebody who has got through early childhood by being good and compliant and suppressing their own needs at the expense of other people's needs, and then reaches a point of crisis in late adolescence when they start to become apparently behaviourally dysregulated, but really for the first time experimenting with and suffering through a realisation that there is anger to be expressed, that they've been ill-treated through their life and they've got resentment about that. If what we do is to try to pacify that protest, then that suppresses it again. And we know that these people have got like this because they have the capacity to suppress their feelings. So really what we're doing is setting them up for a lifetime of disability. Whereas if we can stand by them while they somewhat clumsily express that anger that so far has been suppressed and help them to come out the other side of that experience, then we can actually benefit them greatly. Now, unfortunately, that kind of being with experience rarely happens in the medical system because people don't have the patience or the risk tolerance to be able to tolerate the anxiety. So much of what we do professionally is managing our own anxiety as well as managing the distress that our clients or patients or young people experience. So one of the things that we have to be able to do if we're going to be therapeutic with young people is to be able to tolerate anxiety. It's not to take the course of action that makes us feel least anxious. And it is necessary to acknowledge our own anxiety, and if we're out of our depth, to seek supervision. And there are situations in which we need to take the safe, risk-averse course over the risky, possibly developmental course, because the environment doesn't allow us to do what we think would be best practice. But I think most people are functioning on the spectrum closer to the risk-averse end of the spectrum than the overly risk-taking end of the spectrum. So we should work collaboratively, and these aren't risks that one should take individually. These are risks that one should take collectively as part of a team after careful reflective discussion. But I do think the youth sector is probably more capable of taking those kind of good risks than the medical sector might be. One of the damaging things about coming into the mental health system is that suffering begins to be talked about in medical language, and we lose the capacity to talk in ordinary language about what people are going through. So whenever a young person or their parents tells me that they're depressed, my first question is, depression means different things to different people. Tell me what it means to you. And my favoured definition of depression is the not experiencing of important feelings. Mostly young people I see who are labelling themselves or have been labelled as depression are avoiding something, not consciously necessarily, but there's something that feels dangerous and destructive in their lives that they're avoiding. And so I think grief provides a really good example of that. When we're bereaved, that's obviously a distressing experience, and it induces all of the medical symptoms of depression. But we don't think of that as an illness, or certainly not an illness that requires medical intervention. But sometimes grief goes wrong, and grief is complicated in some way, and a person will avoid thinking about or feeling what's associated with the loss. And you can do that, but there's a cost to it. More and more stuff that's associated with the memory of the person has to be avoided. So your life and particularly your emotional life becomes more and more constricted. And so you don't experience too much pain, but you also don't experience much pleasure, and you don't get interest, you lose interest in things. Your life becomes emotionally very constricted. And so that might be what people talk about as depression. And people get into trouble with that gradually. That as a strategy for dealing with distress, that doesn't work very well. And so people become more and more despondent as a result of that. And sometimes they come to therapeutic attention. And one of the things that we do is to try to overcome the avoidance, help them gradually and in a supported way to start to think and feel about the loss that they've experienced. And characteristically, what young people will say at the end of that process was, that was hard, but it wasn't as hard as I expected it to be. And it was painful, but it wasn't nearly as painful as what I was doing to avoid the distress that I thought I was going to experience. And so, and anxiety, generally, when you try and translate that into something, there's something scary that's being avoided. And the process of avoiding it has been successful up to a point where that's broken down, and the person can no longer successfully avoid it, and the anxiety is starting to well up. But if you can identify what it is that the person's avoiding, sometimes it's not as bad as they think it is. And if you can help them to face up to their fear, it becomes less debilitating. So how do we come to find out what it is that's distressing a young person? Because frequently they can't tell us about it. In fact, usually they don't come to our attention. Usually coming to the attention of someone like us is more or less a statement, something's wrong and I can't say what it is. Because if the person could articulate what the problem was, they frequently are able to find help in other ways. And as I said at the beginning, there is a limited number of ways in which young people can make their distress known to us. They can, use drugs, or get depressed, or get anxious, or get promiscuous, or engage in other dangerous behaviour. And our task is to try to translate that communication back into ordinary language and help them to talk about their experience. So how do we do that? Well, I think there are two main things that I want to focus on in terms of trying to understand what's going on for a young person. The first is to be interpersonal rather than individual. And I start every assessment by drawing a genogram. I want to have a diagram that shows the young person, their parents and their grandparents, siblings, any step parents or half siblings, any illnesses in the family, what everybody does for a living. In the process of doing that, I'm getting a good idea about social determinants of mental health. I'm finding out who the players are in the story of this person's life. Even in people who are completely dislocated from their families, I think that process is really important. There's also a role for a more sort of broader kind of eco-map, which I sometimes find helpful. It's not as high yield as the genogram. The genogram, I would say at least half the time, by the time I've done a genogram, I've formed a meaningful hypothesis about what I think is the young person's predicament. But I'm always trying to focus on the interpersonal, trying to think about the young person's experience in the context of how it impacts on other people and how other people impact on that experience and on that person. And again, that's something that the medical system won't do as well as you might do. And the genogram is like a kind of living, growing document that each time I see the young person, I might want to add more detail to that. And those of you who are working in a setting where you have longer term relationships with young people might find, you know, surprising information in the genogram that illuminates something that's been a mystery for quite some time. So, you know, I remember I often use for teaching an example of a very sassy girl that I was interviewing in the context of, I don't know, truancy or something like that. And she was hard as nails. But when I got to asking about her grandparents, there was a slight softening in her relationship. And very soon it came out that her grandmother was dying of bowel cancer and had been really the only sort of safe base in this girl's life. And she never would have volunteered that information. But once I knew that, it really just radically changed the way in which it was possible to make a connection with her. So that's the first guidance, is to focus on the interpersonal rather than the individual, and the interpersonal fanning out into the social, but of course asking those direct questions about the social. You know, has there been a time when you or your family haven't had food on the table? Is not a bad screening question about poverty. The second thing is to be story seeking rather than fact finding. I want to know the patient's story. So rather than asking what's wrong or what do you think's going on or how are you feeling or those kinds of questions, I want to ask what happened? What happened then? Give me an example. Tell me more about that. Who else was there when that happened? Tell me what happened afterwards. What was leading up to that event? When was the last time before that happened that you were feeling okay? So what changed after that? And I find that if you get people to talk about their experiences, you learn much more important information than if you ask them to tell you their opinions about what's going on for them, what their analysis is. And people with lived experience, you know, you've probably come across the kind of mantra of don't ask me what's wrong, ask me what happened. I mean, there are political and other reasons for that statement, but actually it's also very good advice from the point of view of understanding somebody. You'll find out much more useful information about somebody by asking them what's happened rather than what's wrong with them. I think that's pretty much all I wanted to say to start with, and I'd be pleased to have conversation or arguments or questions.
Thanks, John. That was fantastic. Greatly appreciate that. Thought-provoking as always. So I guess opening it up now to questions from participants. Anyone has any questions for John? You can raise your hand well, I've got one from David, and a lot of people, their video cameras are off. So the way you need to raise your hand if you want me to see it is to go down, hover at the bottom of the screen to see the participant, then basically through there, once you're in the participant, then select raise hand so we can see you in there. But I'll start with David. Go ahead.
Hi, thank you. I just want to ask John, you were talking about asking, you know, the question, what happened? And just going back to the principles of adverse childhood experiences and learning, you know, you've said a whole lot of interrelated things there, but do you find that once you start digging that you get those adverse experiences coming forward in people's lives that you're talking to?
A lot of it comes out from the genogram because, you know, you find out that there was a divorce when the child was 2 or 3 and, you know, the mother was a single mother with 4 children for a number of years or something like that. So you can infer from that. I have mixed experience from from young people themselves talking about it. I don't hold with the view that there's a kind of complete history to be taken from a young person. I think it's a matter of collecting the minimum information you can in order to make a safe and helpful intervention. And so I try not to get anxious about what I don't know. I try to make the most of understanding the young person's predicament based on what I do know. And if I'm mystified about what's going on, then I might need to ask more questions, or I might just need to come up with a more generic, intervention that so if I get to the end of a session with somebody and I feel I don't really understand what's going on here, what I'll usually do is try to put in place some kind of exploratory intervention. I'll ask them to do something that might be helpful, but I don't have an investment in it working. If it doesn't work, I'm going to treat that as an extra source of information and feedback, try to understand better what's going on. I'm not sure if that answers your question, though.
Yeah, it does. Thank you.
John, Jade has put a comment, a question, which is a key question of when would you recommend to make a referral to a mental health service?
I mean, I think that depends on what your relationship, what your knowledge about the mental health service you're referring to is, and whether you have a relationship with them. If you've got a good relationship with the mental health service where you trust the people, it's going to be very different from where you're just giving a referral and it's like going out into the ether and you've got no idea what's going to happen to it. I think if there's something that feels to you to be incomprehensible in a way that suggests that there might be some serious mental disorder, if in your understanding this person appears to be psychotic, if somebody is, so impaired in their functioning that they more or less can't get out of bed, I guess suicide risk is the big one. That would be, I assume, the most common reason why somebody who otherwise wouldn't be referred to the mental health system does get referred to the mental health system. And I think that's something that needs to be a collective responsibility. I think each agency or work group really should be working really hard to take an approach to the expression of suicidal intent or thoughts by young people that involves the minimum safe, the highest safe threshold that can be established for referral on. There clearly is a threshold, but what I'd be trying to, what are the alternatives for a young person who presents with something in the way of suicidal intent? To take an extreme example, if somebody's feeling, the occasional fleeting suicidal thought, and if they were going to attempt suicide, they thought they might scratch themselves with a paperclip, then it's unlikely that somebody's going to refer them to mental health services. Somebody, contacts you and says, "I've got a noose rigged up in the shed and I'm just about to put my head in it," then clearly you are going to refer to police or something like that. But what each individual, and I think this should be at agency level, what you need to determine is, where's the threshold going to be? And okay, so we think the threshold's here. What can we do as an agency to push that threshold up safely? And one important thing, I think, is to focus on suicide, any gesture, attempt, or talk about suicide is a statement to the effect of, "I'm not coping." So what can you or your agency do to enhance this young person's coping? And is that something that might prevent the necessity for a presentation to a mental health service? So I think it's something that you can't say these are the indications independent of knowing the environment in which the youth worker or youth service is operating, because it'll be very different according to what those services are and the relationship with the services. So, you know, whether it would be helpful for someone like me to work with some of your services to try to develop a corporate approach to this kind of problem, that might be a way to go. I'm sorry that I can't provide a more helpful, definitive response.
John, I think that would be something that I would assume in many of the services will find useful, and maybe we should talk about how, as a sector-wide, we can work with the broad breadth of the youth agencies and engage you in something like that. Any other questions coming? I got one from Vicky. Go ahead, please, Vicky.
Thank you. Hi, John. I just think this is fantastic to hear, as other people are putting on the chat there. I just think this is a really great way of looking, and we see it very often here that young people are more than happy to engage with us here at our youth centre, but once a referral has gone through, that attendance, it doesn't follow through. And so very often we're left with young people who have disengaged from KIMS, have decided not to see a psychologist, and they would rather see us, that present with quite complex needs that we have, I would say, some good skills to deal with. But my, I suppose, question is, I wonder if there is a gap, and I think in an ideal world, I'm just thinking I would love to be able to work more with these young people, but I'd also love to be able to tap into the expertise of psychologists and psychiatrists, perhaps from KIMS or somewhere else. But there seems to be a bit of a gap for professionals in my situation to quickly tap into help. What do I do here? These are my ideas. Can you just kind of give me some backup? You know, but I just wonder if that's something that you can talk to, whether you've seen any good experiences of that collaborative work that could happen between youth workers, social workers, and psychologists in the mental health system.
Yeah, so I mean, I kind of trained and grew up in what's called consultation liaison psychiatry, which is providing psychiatric services to hospitals, to the non-psychiatric patients in hospitals. And the way in which you work in that setting is that you see patients yourself, but and that's largely about establishing your credibility with your colleagues. And once you've established your credibility, the task is you shift over to supporting your colleagues in doing the work themselves. And I've always thought that model is the way that we should function much more broadly in psychiatry. We need to be doing a core of work ourselves, to maintain our skills and our credibility, but we can do much more good by supporting a wide range of other people to work with many more young people than we can. But unfortunately, that's not the way the system works. You ring up and you want to have a talk with somebody, and you kind of get, well, here's the form to fill out a referral, or send us a letter and we'll deal with it. And but whether you can, it might work locally. What doesn't work globally might work locally. So if you can kind of charm somebody from your local KIMS team to form a relationship with them and say, we'd like to experiment with this. And the ticket in is to say, we think we can prevent emergency presentations to your emergency department if we can, form a relationship. And that people's eyes light up at that, because that's a KPI that they have to address. So it becomes an incentive to be a bit more innovative.
Vicky, there's also a comment there in the chat box if you want to follow up. Catherine has made a suggestion there for you. Kate Ryan, Kate, please go ahead.
I just wanted to jump in on the back of Vicky's comment there, because we work very similar contexts in the same region. And I suppose one of the other gaps that I see is that young people, as John said, are avoiding something, or they're expressing some discomfort with something that's happened, it presents with these symptoms that have been labeled mental health issues. But the mental health services don't have a response to deal with the historic stuff. They're only focused on what's happening right now around the risk. And there's a really big gap in accessible, affordable psychology to process some of the trauma and some of what's happened historically.
Yeah, I mean, I think that's a very real, I mean, but that's not the way the system should work. I mean, no mental health practitioner should be, I mean, there are situations in which you have to make a quick triage decision based on, the available information. But we must always be interested in and curious about all of those factors that you've talked about. And when you encounter somebody who's not interested and curious, that's just poor practice. That's not the way the system should function. Neither you nor I are in a position to change that, unfortunately.
Sure.
Can I just interrupt for one second? I just need to attend to something. It'll only take me 10 seconds.
Go ahead, John. While we're waiting for John, anybody else has got a question? Any comments, questions? Who's there? I can't. Hang on a second. Is that Anna?
Yes.
Yes, go ahead, Anna. John's back. Please go ahead.
Yeah, this was, I guess, really refreshing to hear from John. I work at a headspace centre, and a number of the young people that I work with, by the time they've come to us, they can rattle off these diagnoses and labels that they've been given. And I really agree it's really powerful to do like the genogram and things like that to help them connect the dots. I wanted to hear your perspective on how do we help them resist this pathologizing, of their life experiences in this medical model.
I think it's about trying to develop with them an alternative language, which is obviously easier said than done. I mean, I think, and you're also working in a setting where there is a requirement to provide diagnoses for people. At what used to be when I last had anything to do with Headspace. So you're kind of working against your own system in a way when you're trying to get people to use different language. I express my skepticism about the usefulness of labels when young people sort of almost want to celebrate their labels. Things were really difficult for me until I discovered I had borderline personality disorder. Now I know what's wrong with me. I mean, it's difficult for me as a clinician to challenge that. If other people with lived experience challenge it, which I've seen done, I've seen in response to a question like that, another person say to them, that's really sad that you see your life like that. Can't you be a bit more positive about things? Can't you acknowledge that you're the way you are because you've had a shit life and you're now in the process of overcoming it? But, there's small incremental steps, I guess, that where we're operating against the prevailing view. And, the idea of destigmatization, there's a strong investment in promoting these labels in order to make them more acceptable so that people don't feel stigmatized by having the labels, rather than avoiding using the labels when you wouldn't be stigmatizing the person in the first place.
John, you're mentioning labels, and I've got a question, if I can just jump in. But before I pose the question, I might preface it with two quotes. And the first one is a quote by Professor Thomas Szasz, the famous American-Hungarian psychiatrist who died in 2012. Professor Szasz maintained that unlike true disease of the brain and body, mental illness is a destructive social construct that medicalizes living and deprives people of their dignity. According to Szasz, medication, hospitalization, and mandated psychotherapy are a little more than coercive, dignity-reducing form of clinical practice. The second quote is by Dr. Bob Jacobs, who some of you will remember from his work with Yank over the years around the overdiagnosis of children with ADHD and the overuse of stimulant drugs. Dr. Jacobs suggests that if someone feels distressed about anything, they may want to address it. If I want to increase my arm strength, I can go to the gym. And if I want to understand myself better or feel less sad, anxious, distrustful, I can see a therapist or engage in other forms of self-help. But maybe we don't have to conceptualize these things as sickness. And maybe we need to take a hard look at the validity of the term mental health. So my question to you, John, is being aware of how powerful language is and its influence on our behavior, should we be conscious about using the phrase mental health? And perhaps should we be looking for an alternative?
Yeah, I mean, the trouble with finding alternatives is the alternative tends to just become, so we talk about mental health rather than mental illness, but mental health just becomes more or less, and then you get the kind of linguistically silly thing of mental health illness or mental health disorder. I think replacing terms with other terms doesn't really work in the long term. The new term just comes to have the connotations of the old term. I think it's a matter of minimizing the use of any terminology and trying to talk about to each individual about what's happened to them, and to try to use ordinary language wherever possible. The thing about depression and anxiety is that they are ordinary language terms. So that's kind of confusing. I can say I feel depressed because, I don't really feel like going to work this morning, and or I can say I feel depressed because I've got, a life-threatening condition, and it's the same term. So there's always going to be ambiguity in language. I think that we do need to be careful in the way that we talk, and the less jargon we use, the better. And reserve the jargon for those situations in which there is, it does have, because there are harms and benefits to labels. And, I'm inclined to focus on the harms, but we do have to acknowledge there are benefits. And there are situations in which the benefits do outweigh the harms. I would say only a small minority of cases, but there is a place for labels, and no, we haven't got the labels right, and we could come up with better labels, but I don't think that's where we should be expending our energy. I think we should be expending our energy on focusing more on social determinants and individual understanding of an individual's predicament in interpersonal terms. And Zaz, I think, is nearly right. But, we have to remember that there are mental disorders that are quite clearly physical disorders. I mean, syphilis used to be the most people in asylums had syphilis. And when penicillin came along to treat syphilis, a lot of people didn't need to be in asylums. That's not a social, the fact that they were in asylums, sure, but it wasn't a social construct that they were suffering from a mental illness. It was a spirochete that was causing that. So we can't be completely dismissive of the concept of medical disorders manifesting in a psychological or emotional way.
Thanks, John. Cynthia's asked, what is the role of the sector in supporting parents, friends, family to support their young persons? So this is for young people who have some supportive adults in their lives.
Yeah. And, it's very easy to get a negative view of parents and to think that they're responsible. And I'm not infrequently accused of parent blaming because I want to acknowledge that parents are the most powerful influence on children. And if something goes wrong in parenting, that often manifests itself in distress at the time or later in life. But as well as being, because they're most powerful influences, they can also be influences for the good. And because they've been harmful influences in the past, doesn't necessarily mean that they're going to be harmful influences in the future. Now, there are, of course, sometimes parenting situations that are completely irredeemable. But I think we should always be wanting to work with parents if that is available to us. And I'd hate for an agency to isolate itself completely from working with parents, even if the primary mandate is to work individually with young people.
Thanks, John. Anyone else has got any questions for John? I'm not seeing any hands, anything at the moment. Well, we're almost up to our hour, and as I mentioned earlier on, is that I'll follow up with sending you all a link to a Survey Monkey, so you'll have an opportunity to make further statements, ask further questions, and there would be a report that will come out of this as well. So I'll compile a report. If you've registered, your email address would be here. So we'll also send you a report of this. And finally, one thing that has come out, I guess, strongly, I think John will definitely take you on in terms of exploring if we can work out a way that for you to continue working with the sector, whether that's with individual agencies or collectively as a whole, to develop some sort of a protocol in terms of how youth workers can engage with young people and at what point particularly they should consider referral to clinical services. Because I think that's probably will be a major helpful tool for a lot of youth workers out there, so that we can proceed. Any concluding comments from you, John?
Thank you very much for having me and for the interesting questions that you asked.
Thank you so much. Greatly appreciate in middle of your holiday on the beach, taking the time, John, as always, donating your time so kindly. We really, really appreciate that. And so if I can give everybody else, get everybody else also to join me in giving John another one of those farewell Zoom styles that he can see. And thank you again, all. Appreciate everyone that joined in. Hope you got something out of the meeting, and we'll be following up with the emails. Have a good day, all.
Thank you.
Bye.